Thanks, Becky. Becky is an advanced clinical practitioner with us at the Royal London, who works with us on the A&E, Pediatric A&E Registrar rota, and she's got a wealth of knowledge, particularly around managing minor presentations in A&E. So please stay with us until the end. It's expected to be an amazing session. Becky, all yours.
No pressure. Thank you very much, Harris. Yeah, as Harris said, I'm a PEDS ACP. I've been asked to talk to you today about minor presentations in paediatric A&E. And I've had a bit of a think about the kinds of things that you really need to know if you're going to be working in PEM, but you don't necessarily always find in a book or get taught. And these are the things that can often kind of catch you out on the hop. So I've got a few things that I want to talk to you about today, and I've split it really into 3 chapters. The first one is foreign body removal, the second one is face and mouth injuries, and the third one is kind of miscellaneous items that I find really useful in my day-to-day practice, and I hope that you will too. I'm happy for you to ask questions as we go along, either using the chat, which I'll try to keep an eye on, or as Harris says, just unmute yourself and chip in when you're ready. So the first thing I'd like to talk about is foreign body removal in paediatric A&E. These are some of my favourite presentations, to be honest, and they can be really, really fun. Unfortunately, they have the potential to go quite badly. But the difference between going well and going badly is usually down to how you prepare for them. So I'm going to talk you through the way that I think about preparing for foreign body presentations, and the kinds of things that I do that hopefully maximise the chance of success. So the first thing really is thinking about what's in there, so that you're going to get the right tool for the job. And I'm going to think about those tools a bit more in a minute. Get the right people involved. For me, that always means getting the play specialist involved. And if you don't have one of those around, then ideally have another colleague whose only role in the proceedings is to focus on distracting the child. Because really, I think this is a one-off offer. You've got one opportunity to get this right. The first thing I'm going to talk about is foreign bodies in the nose. And these often come out without using any form of instrumentation at all. And the technique we usually use for those is the kissing technique. I'm going to show you a video of the kissing technique, which is actually one of our PEM consultants and her daughter, just to demonstrate the technique, and I'm hoping you're going to be able to see this okay. So it's not always that hilarious, I have to say. So the first thing is to position the child normally sitting up so that gravity is on your side, and generally kids aren't quite as cooperative as this, so ideally put them on the side of their parent's lap with one of the child's arms under the parent's arm to get one out of the way. If you hold the child's head from behind, you can normally occlude the unaffected nostril, then get the parent to put their mouth over the child's mouth to create a really good seal, get them to give a really good short, sharp breath, and hopefully the foreign body will shoot out. There's usually a fair bit of snot involved, and then you're running around on the floor to try and find it as it rolls across the room so that you can give it back to the child. Some parents are just unable to do this technique, or they just can't really face it. And for those people, you often use a bag valve mask. So what you need to do is to use the bag valve mask in place of the parent's mouth, clearly. So choose a mask that's just going to fit over the child's mouth rather than their mouth and nose as you normally would. Again, hold the child's head from behind. This is a two-person technique. So if you hold the child's head and occlude the unaffected nostril, then you can get one of your colleagues to operate the back valve mask with a short, sharp burst. Just remember to occlude the pop-off valve, because otherwise you won't generate a high enough pressure to be able to get the foreign body to come out. So that's the first technique. Oops. The second thing that I want to talk about is the tools of the trade, really. So I think an absolute game changer for me in managing foreign bodies has been to have a head torch available. I always used to find myself, particularly in ears, trying to hold the ear with one hand, a tool with the other hand, and then try to position the torch in my mouth, which just, it's not a good look and it doesn't really work. So get a head torch, keep it somewhere handy in your department. You'll be amazed at the number of times you'll use it. That's the first thing. Then think about other tools and try to work out what you think the object is and what the best tool is to get it out. So the first thing that we often use is some suction, and that can normally be just a yanker sucker that we've got plenty of in the department. These are really good for objects with a smooth surface, so things like beads and polystyrene balls and things like that. Just warn the child first that it's going to be noisy, so I normally just put it close to their ear so that they can hear the sound that the suction is going to make, so that they don't jump when you start doing it. I'm going to show you a video of how that works now. And I think the person who is the clinician in this video may even be on this chat. If you are, thank you, Beck. So she's using a head torch. You can see what she's doing, and just pull the pinner back as you insert the suction, and you should, once you've got the hair out of the way, be able to get the foreign body out of the ear fairly easily. Oops, just go on to the next one. So the next useful piece of equipment is the Crocodile Forceps. These are really good for soft objects, so things like cotton wool, balls of tissue, that kind of thing. They're also really useful, and this is a top trick, if you magnetize them by putting some magnets on the shaft of the Crocodile Forceps. That means that you can often get things out that are slightly deeper in the ear canal. So that's been useful for me. Things like when children put the back of an earring in their ear, you can often magnetize your Crocodile Forceps and get the foreign object out that way. You can, if you don't have magnets available in your department, often the magnet on your name badge will do the trick, or you can often use the magnet to get metal objects out of the nose. If you just run the magnet down the side of the nostril, it's often useful to get foreign objects out that way. That's just going to show you that magnetic trick. Okay. And in action in the ear. Okay, so the third piece of equipment that's often useful is a syringe with some water. Warm water is nice. This is often useful for things that either float or disintegrate. So I've used this quite successfully for things like Play-Doh. It's often useful for polystyrene beads. Sometimes if you've got a whole load of tissue in there, you can wash it out. It's useful often to just add a little nozzle on the end with a cut down NG tube. so that you can direct it a bit more easily into the ear canal. And you can see that in action here. Here we've used saline, but it's perfectly acceptable just to use warm water in the ear. It's a very compliant child. Okay. Good. Okay. So then a couple of other useful tools. So the Jobson horn probe is useful to get behind things in the ear, often useful for round things that are heavier and don't want to come out with suction. So that might be things like beads or a popcorn kernel we used it for the other night. So you do need to make sure that there's enough space around the foreign object that you can actually get behind it with the probe and pull it out that way. If you're just touching the surface of it, you're just going to make it deeper, so just be aware of that. And similarly, the wax hook is really useful. You can get behind things with the wax hook, but often if you've got things in there that are a bit softer that you can't quite grab hold of with the crocodile forceps, you can sometimes hook into them with the wax hook and get them out that way. I think I've got the odd pea or piece of sweet corn out with a wax hook. That tends to work quite nicely. When all else fails, if you've got something stuck often a bit deeper in the ear that you can't get behind and you can't get hold of, you can try a cotton bud with some glue on it. So you need to use your normal wound glue, just put a dollop of it on the end of the cotton bud, put it very carefully into the ear canal. You need to wait a good 30 or 40 seconds and then you can sometimes pull out the foreign object on the end of the cotton bud. This is a technique that can work, but you clearly need to be really careful with it because there is a chance that you're going to either stick the cotton bud to the ear canal or end up adhering the foreign body to the ear canal. So just be aware of that. I think my main message about foreign body removal is if you're not succeeding with this, just stop. As I said earlier, you do get probably one chance at this. So get everything prepared. So that means getting yourself prepared with the right amount of kit and the right tools for the job and getting the child prepared. So ideally get them properly distracted, properly positioned, and with the right amount of support from the parent and the play specialist and so on. If it's not going well, then you're going to need to stop. Maybe think about a different technique or think about referring them on to ENT so that they can get it out a different way with different equipment. Equally, there are some children who just will not be able to tolerate this. Either children, who are very distressed, or the very young ones, or children with behavioural problems who just can't get on board with this. And actually, we just don't want to distress them. So if success doesn't feel like it's even possible, don't even try. Okay. So the next thing I want to talk about is facial wounds. This is a really common presentation in ED, and it's something that we often get asked about. Can we close this? Do we need to refer? And I think probably it depends where you work. If like me, you work in a place where you've got max fax on site, you probably refer a lot more than maybe you need to. And in other places, you need to be able to make a decision about what you can reasonably repair yourself and what needs referral. So I just want to think about kind of a bit of an approach to evaluating what you're going to refer and what you can manage yourself. So I think there are only a few absolute rules when it comes to what to refer, but there are some areas that need a bit more thought, and that depends really on your skill, on the child's age and their temperament and the support that you've got in your department. And that might mean play specialist support, what seniors you've got around, and whether you've got plastics or max fax on site. So there are a few special areas that we worry about on children's faces. So the first one of those is is the Vermilion Border. Obviously, we spend a lot of time looking at people's mouths when they're talking, and any imperfection in the closure around the mouth is going to be really, really obvious. It doesn't mean that Vermilion Border lacerations can't be closed in A&E, but they do need a bit more thought. You need to be sure that you can do it properly, and the child does need to be able to be kept still enough for that to happen. Eyelid lacerations are always a challenge. Clearly, the full thickness ones are going to need referral to ophthalmology, and anything on the eyelid just requires a bit of thought in terms of how you're going to get it closed because of the method of closure. And again, making sure that they're properly aligned. Clearly, if it's right on the edge of the lash line, they're going to need to be referred to ophthalmology because, again, cosmetically that's potentially disastrous, and also it might result in imperfect eye closing. So nostrils around the edge of the nose, particularly if it's right on the edge of the nostril and if it's full thickness, that needs to be carefully thought about. And I think in children, most people would refer those to MaxFax so that they could be closed probably under a GA. Ear cartilage lacerations have the potential for being poorly aligned and therefore cosmetically really difficult. So again, just think about referring those. And anything around the medial aspect of the eye and the lacrimal duct needs to be thought about. So think about the underlying anatomy there, because any injuries there put you at risk for injury to the tear duct, and they need referral to ophthalmology. These are really rare injuries in children, and they just need to be referred. So think about not only those areas that I've described, but think about depth. So really anything into the skin or the fat is okay. You can probably close that yourself in A&E. Anything deeper is likely to need referral to plastics and may need closure under a GA or sedation. Think about whether there might be any foreign bodies in the wound. So children might have fallen on a glass coffee table, there might be glass in there. Children who've fallen off their bike might have gravel in there. And occasionally we see teeth embedded in lips, and they clearly need to be removed before the wound is closed. So get a soft tissue X-ray if you're in doubt about those. Check that there's no neurovascular damage around the wound. So just get the child to make some funny faces for you and check that their facial movement is normal during smiling or crying or raising the eyebrows or whatever. If there's any abnormal facial movement or you're worried about neurovascular damage, they must always be referred to MaxFax. And again, if these are significant mechanism injuries, so for example, older children who've fallen off bikes or whatever, just make sure that you're assessing for underlying fractures before you close the wounds. The shape of the wound is equally as important as the location. Because the elasticity of the skin causes retraction around the edges if it's not a linear wound, it makes those edges much more difficult to approximate. So it's not an absolute no for closure in the ED, but they do take longer and they do require a bit more expertise. So for example, if you've got a wound that that's a V shape or a T shape, do you know how to do corner sutures? If in doubt, you're going to need to refer those. Often children have been bitten by dogs because they're forever annoying dogs, and those clearly require a bit more thought. We used to always say that they should be left open for a bit longer, but actually most of the research recently shows that they can be closed as long as they're adequately cleaned. and most people would give antibiotics for those wounds. So just be aware of those. Think about Langer's lines when you're going to close the wound. So even in the lower risk areas, think about direction and whether wounds cross Langer's lines. Especially have a look at the forehead. We often see children with forehead lacerations. Clearly that's where they get them over the bony prominences. Lots of them are either just above or just below and parallel to the eyebrow, and those really come together pretty well. Sometimes we get kids with lacerations down the middle of the forehead. Just get them to raise their eyebrows and give their face a bit of a wiggle and see what happens to that wound when they're moving their face, and that will give you an idea of the tension on that wound. They can be closed in ED, but often they need some subcuticular closure before you close the surface. So if you're in any doubt about those, get somebody who's experienced in wound closure to have a look. Just bear in mind the potential for NAI, obviously, and any wounds that are not over bony prominences, just have a bit of a think about those. So if you're going to close them in A&E, most of them can be done either with glue or with steri-strips. I particularly like steri-strips because you can approximate the wound just bit by bit. And you can get it perfect. So you know, you can start at one end and get it a bit closer and a bit closer, and then take the first one off and get it really as perfect as you can. They're often useful if you're worried around Langer's lines and you want to have a bit of a test of the tension and the cosmetic outcome. So my recommendation, unless it's a very hairy area, would be always to start with strips. You can add glue later, but strips give you a bit more flexibility. You can use glue as a dressing if you need to keep the strips on, particularly in children who are likely to pick them or dribble on them. Just be really careful about using glue near eyes. Obviously, we don't want to glue the eyes together. So I normally again start with the strips, and if I'm going to use glue near an eye, then I would normally put a big pad of damp gauze over the eye and get someone else to hold that in place, just because then you're not going to get caught out if the child moves suddenly. Some people like to cut a little diamond shape out of a piece of Tegaderm and put that over the wound so that it's not going to dribble onto the skin. I find that a little bit faffy, and I usually use the gauze, but the message is do something to prevent that glue dribbling down into the eye. Also keep your fingers out of the way so that you don't end up gluing yourself to the child. Yeah, I'm going to tell you some tricks for how to get yourself out of that mess in a minute. If you're going to suture a wound on the face, then they should always be absorbable sutures, and really nothing bigger than a 5/0. So generally speaking, simple interrupted sutures are absolutely fine on the face. Don't ever use forceps to hold the skin edges. All you're doing is making a hole in the face with the tooth forceps. And we just need to be so careful with maintaining the integrity of the skin around these wounds on the face. So even instilling local anaesthetic can distort the edges of the wound around the face. So think about using a nerve block instead of local, or use Lat gel, which often works incredibly well in facial wounds for children. Sometimes we can suture just under Lat gel without even using any local as well. Even just irrigating copiously can distort the wound edges. So just be really aware of anything that you're doing in terms of cleaning, irrigating and putting local in around these facial wounds. Really, in terms of referral, the question I ask myself is, does this child need a GA? So I think that's a good rule when it comes to referring. Really, it's about, you know, have we got the skill in A&E to do it? So maybe we can get the skills down and get the child, get their wound closed under ketamine if that's available in your department. But really, if they need referral, the question generally speaking is it because they need a GA for cleaning or closure? Parents always ask, is it going to scar? And my answer to that is all wounds are going to scar, but there are some things that you can do to minimise that. So advise the parents that once the wound is healed, they should massage it regularly with oil, and that might be bio oil or whatever kind of oil they've got, vitamin E cream, whatever. So really the massaging motion is the important bit rather than what they're putting on it. And they should do that really, you know, once or twice a day over the course of weeks and months, because that skin is likely to be remodeling itself for up to 6 months or so, and it's they can make a big impact on the appearance of the scar if they continue to pay attention to it over that time span. Advise them to be really fastidious about applying sun cream to their child's face, even on, you know, dull days, because exposure to the sun is very likely to increase the appearance of the scar. And so just as we would tell parents when children have presented with burns that they should be really careful about sun cream, we should tell them that after facial wounds as well. Okay, so I just want to talk next about tongue and oral mucosa wounds, because I think these cause quite a lot of distress, mainly to the parents and sometimes to us, but actually most of the ones that we see in A&E essentially need not much doing. So really the rules are just have a look. If there's a wound on the top of the tongue or on one surface of the tongue, check that it doesn't extend through to the other surface. Those full thickness wounds are at risk for fistula formation, and they will need closure by max fax in theatre. Any pieces of tongue that are kind of hanging on by a thread will clearly need to be sutured, largely because they're going to get caught in the teeth and cause problems when speaking, eating, feeding, and so on. But most of the ones, you know, even up to a couple of centimetres across, do heal themselves really well. Even if they're gaping, they will sort themselves out, and that goes for oral mucosa wounds as well as tongue wounds. Bleeding can be a bit of a problem, and if they're persistently bleeding and you either can't assess them or they're causing distress because of that, then you can use some adrenaline or TXA soaked gauze. I have to say, if it's not mega bleeding, I usually get the child to try an ice lolly first, because that usually works really well and it's much better tolerated. So that would be my first line of action. But yeah, you can progress to adrenaline or TXA if you need to. Tell the parents that these wounds are likely to look worse before they look better. They usually look really white and sloughy and horrible for a few days. Just make sure that the parents are warned about that, because otherwise they think that they're infected and they're likely to come back when they don't need to. Okay, I'm checking the chat. If there's anything you want to ask as we go along, please do, but I think there's not much happening yet, so I'm taking that as a good sign. Okay, so I'm going to move on to dental injuries. And I think the emergency management of dental injuries that we're going to get involved in paediatric A&E is actually fairly limited. But there is an opportunity to make a really positive difference to outcomes with just a few actions. You don't need to do much, but it can make a big difference. So dental injuries are really common in preschool children. Most of them just involve chipped teeth, and most of them don't really require any action. If a child presents to you with their tooth in their hand, clearly that's okay, you know where it is. If there's any chance that they've aspirated that tooth or that it's embedded in the lip, then we do need to know about that. So just be really careful about the history. You might need to do a chest x-ray to check whether it's been aspirated. You might need a soft tissue x-ray to check the soft tissues of the lips or cheek, because sometimes a tooth fragment can get embedded into the lip, and clearly that needs to be removed before well, before you close it. You're probably not going to need to close it, but it will need to be removed. And you may also need to do an OPG, and they can often be useful either if you don't know whether a tooth is deciduous or permanent, or whether when you can just see a very small portion of the tooth and you don't know whether the tooth has been fractured or whether it's intruded into the gum. I'm just going to look at various different things that can happen to teeth. So there are a few things that can happen, and I've shown a few on the slide here. So subluxation of the tooth can happen after mouth injuries. So the tooth will be tender and it will probably just feel a bit mobile. The extruded teeth, when it's almost out of the socket, so it looks longer, it looks like it's hanging out, and they're really wobbly. Intruded teeth are the ones that have gone up into the gum, so they look shorter than they did before, and they're a bit difficult to tell sometimes whether the tooth is intruded or whether it's fractured. And as I said, if there's a doubt about that, then you may need an OPG. The luxated tooth is the one that's been knocked and it's hanging on at the wrong angle, and I'm going to tell you in a minute what we need to do about those. So there's just one other thing. They can also get concussed teeth. So they've got a really tender tooth, and it hurts when they touch it or when you tap it, but it actually doesn't move, and those are absolutely fine. You can just give some pain relief for those. You don't need to do anything with them at all. It's really useful as a starting point when you're thinking about dental injuries to work out whether this is a primary or a secondary tooth. So is it a deciduous tooth, it's one of the baby teeth that's going to go anyway, or is it a secondary tooth that we need to look after for life? Most kids and parents know what it is. If you can't work it out or they can't work it out, there are a few things that you can do to work it out for yourself. So generally, deciduous teeth are whiter than the secondary teeth, and they're often smoother on the edges. When children have got new secondary teeth, they often have bumpy edges because they haven't yet been worn down by eating. And so those are ways that you can tell. So the intruded deciduous teeth are often pushed up into the bone when children fall, often onto coffee tables or over the handlebars of a bike or whatever. And really the management of these intruded teeth depends on the direction and the degree of the intrusion, because usually when they're intruded, as in pushed up into the gum, they're pushed away from the waiting secondary teeth underneath if they're primary teeth. And so they don't generally need much action. The ones that are a problem are if the baby teeth, the primary teeth, are pushed up and back because they can affect the growing secondary tooth. Most of these actually do completely fine, and they should just fall out. The primary ones will just fall out on their own, and the secondary ones will grow down as they normally would. You can generally help that along if if the primary tooth is sticking out, then you can assume that the small root of the primary tooth has gone in a bit. If you can just straighten that up, that's likely to help. And then you can just advise the child to be seen by their own dentist within a few days. Time is normally fine. They don't need much else doing. Intruded permanent teeth can often be repositioned by you just by holding them and pulling them back into position. They're often a little bit wobbly once they've been traumatized, such that you can reposition them fairly easily. If they're wobbly afterwards, then you need to splint them, and I'll talk about that in just a couple of minutes. Those are probably worth discussing with MaxFax if you have them on site. If not, then get the child to see their dentist within 24 hours or so. Teeth that come in the child's hand, if they are baby teeth, primary teeth, we don't do anything at all with those. You can just refer those straight to the tooth fairy. They don't need anything doing at all. If they're out a little bit and they're primary teeth, but they're not fully out, then we don't really do much with them at all. Some of them can just be repositioned if they're not too badly malaligned, but generally speaking, you can just leave them alone. If they're out such a long way that they're hanging on by a thread, then probably the easiest thing to do is just to pull them out. Remember that these primary teeth actually don't really have much in the way of root, so often you can just use a bit of local anaesthetic, or not actually, and just grab hold of the tooth either with a gloved hand or with some gauze and just pull it, and it will come out fairly easily. The extruded permanent teeth do need to be repositioned, and this is a dental emergency really, just as the fully avulsed permanent teeth are. These need to be dealt with quickly. So the permanent teeth have really only got about 60 minutes of viability if they're dry. So you've got to act fast with these. Ideally, get them back into the gum, and we'll talk about that in a sec. If you can't do that immediately, then ideally store them in milk or saline if you haven't got any milk. The first thing that you need to work out about these teeth is it a baby tooth or is it a secondary tooth? And we've talked about that already. So the primary teeth you're just going to leave out, let them take that home and put it under the pillow, and the adult teeth you're going to store in some milk until you can get that sorted properly. Remember that you need to be really careful not to touch the root, because that can damage the really quite delicate root, and then they're much less likely to be successfully reimplanted. So only hold on to the crown, the bit that you would normally be able to see. After you've stored it in milk, if you can't deal with it immediately, then irrigate the socket to get rid of any clots and debris in there, because that makes revascularization much more likely. Then just put the tooth gently back into the socket. They generally go in fairly easily. After that, you can just dry it off and then make a splint if you're not going to be able to get the MaxFax team to come and have a look at it pretty urgently. So I'll just show you a splint that's a kind of a useful way of doing this. There are two main ways of doing splints for teeth that you've re-implanted. So what we're trying to do is just make sure that the tooth doesn't fall out again, and particularly that the child doesn't swallow it or aspirate it. So what you can do just as a temporary measure is to re-implant the tooth, dry it off as best you can. Then you can use some tissue adhesive, so whatever wound glue you have in your department, and then just make a splint. So either you can use the metal bit from the nose bridge of the oxygen mask, which you can cut down and smooth, or you could use the foil packaging from a suture pack or a stitch remover, and then just stick it across the two teeth that you're the wobbly one and the one next to it to try and splint it. That will do the trick as a short-term measure until Max Fax can get down and sort it out more definitively. Just another tip, occasionally I've been faced with a child who's lost more than one secondary tooth in this way, and it's been a little bit challenging to work out which one's which and which order to put them back in. I had 3 out once. It's really useful if you can just get the parent to show you a picture of the child on their phone, because then you can, if their teeth weren't perfect in the first place, you can usually work out which one was which from that. They do need to be up to date with their tetanus if you've re-implanted teeth, so just boost them if they're not already up to date, and just give them some antibiotics because they are at risk of infection. And yeah, it would be such a shame after you've done all that good work if it then got infected. Okay, so I'm now going to move on to the miscellaneous section of the talk, and just talk to you about a couple of things that I think you absolutely should know if you're working in pen. So we've probably all heard of pulled elbows. This is an injury of primarily the preschool age group, often children from kind of 1 to 3. Usually after a pull on the arm, often where the parents try to grab the child to stop them running into the road, or one of those games where they're swinging their child up in the air between two parents. So generally speaking, these are injuries that are fairly innocuous and can be reduced quite easily. They generally don't need an X-ray, and the following criteria really need to be met if you're not going to X-ray them. So remember that the pulled elbow is actually the subluxation of the annular ligament. So if you think of the annular ligament around the head of the radius as a scarf, when it's in a pulled elbow, the annular ligament slips over the head of the radius and looks more like a hat. And what we're trying to do when we reduce the pulled elbow is to get it back into the right position. On an X-ray, it's going to look normal. So there's really no value in doing an X-ray if you're convinced about the mechanism. So really, history is really important. Then when you examine the child, it should look like a pulled elbow. So the child will generally be hanging their arm down by their side. It will be fairly flaccid. They won't be using it, but they won't really be in pain. So it should sound like one in the history, and then it should examine like one. So what I mean by that is the child is generally not in pain, so they're playing, probably using the other arm. When you touch the arm, they're probably not in pain. They'll tolerate extension and flexion of the elbow, but they really won't like pronation and supination. If all of those criteria are met, then you can absolutely try to reduce the pulled elbow without X-raying. And I'll just show you quickly a video of how we do that, I'm hoping. There we go.
In this video, we're going to show you how to reduce a pulled elbow. There are 2 widely recognised manoeuvres. In the first maneuver, stabilize the child's elbow with one hand and with the other hand, grab their wrist and forearm and gently hyperpronate. It doesn't matter where you put the fingers and thumb of the hand stabilizing the elbow. In the second maneuver, stabilize their elbow again and gently flex and supinate the forearm. Review the child in 30 minutes. If they've not started using the arm again properly, you might need to think of other differentials.
So that's fairly easy. There used to be a load of debate about whether you should hyperpronate or hypersupinate. Recently, there was a case series of somebody who looked at all of that. They reckon that hyperpronation is the way forward. I have to say, I usually hyperpronate and that usually works. If it doesn't, then I supinate and that pretty much always works if it hasn't worked first time. I do usually say to people that you should feel like you're pronating the elbow a little bit more than you think you should. And then you generally feel the click under your thumb over the radial head. Oops, I can't get that to go on. Oops, I'm so sorry, I can't get the slide to progress. That's bad. Oh, I'm really sorry, I can't get this to work properly. Just one moment. Okay, I was just going to talk to you about hair tourniquets. So I'm just going to stop sharing the screen for a second while I sort out the I'm so sorry. Okay, I'm just going to have to pause for just a second. Okay. Just got some videos, pictures that I needed to show you. Okay, right, I think we're back in business again. I'm hoping you can see that. Can you see that okay? Yes, good. Thank you, Charlie. Okay, so I'm just going to talk to you briefly about hair tourniquets, which I think we see from time to time in PED-CD and often are a bit worried about them because we might not have seen them before. That picture on the right, you can very clearly see the hair around the toes of this baby, but the one on the left, really not so much. And these are often, these usually come in newborn babies, so generally babies up to the age of a couple of months. They often come in with parents having noticed a really swollen or red toe, and they're often really worried. Babies can be really unsettled because of this, and often they can be the babies that just come in with a history of crying. So I often think if you're seeing a crying baby but you're not able to work out why, then do check for a hair tourniquet. It's worth doing that. These are actually easier to manage than you might imagine. So the one on the right, you could probably reasonably unwind if you had good eyesight and a pair of fine forceps. Equally, the way that we usually manage these now, as long as the skin's not broken, is by using hair removal cream. So I've shown some Vita here, clearly other brands are available. And the way to do that is to put some Vita or some other hair removal cream just around the hair tourniquet. Leave it initially just for a few minutes until the hair starts to dissolve. You can leave it up to 10 minutes, but I normally kind of check it at 3 minutes and then every minute or so after that. Often that works. The next step up from that is to use a little cutting needle, so this similar that you would use for suturing, and again, often you can just get under the hair and cut through it, and just make sure that you have removed all of it. And if you're in any doubt, then refer on to orthopedics so that they can monitor that and have a really good look at it. The ones that are incredibly deep have often got circulatory compromise, and the toes can come in looking almost black. Those are emergencies because the toes can become necrotic, and so they need to go to theatre and have that the hair tourniquet removed under a GA because they generally need to make an incision right down to the bone for those. Be aware that you can get hair tourniquets in other places. So I think it's most commonly toes, but it can be fingers. It can also be around the penis, and it can also be around the clitoris. So just look out for those if you're seeing funny swellings of appendages or in crying babies. And just one final thing that I wanted to share with you, really based on a couple of issues that I've had lately, that I've needed to remind myself of this. So I've sticky problems. So either these can be kids who've come in having glued either bits of themselves together or glued things to themselves. So either when they're older kids doing modelling or whatever. I had a young lady the other day who'd managed to glue 2 of her fingers together while she was applying some faint nails. And equally, this can be because you've unwittingly glued a child's eyelash together or eyelid together. So the first thing is, if it's around the eye or if it's in a delicate area, then you can often release glue by using either some white soft paraffin or some chloramphenicol. I had a child the other day who had their eye completely glued together, not in our department, I might add, and we managed to unstick that with some chloramphenicol. And equally, if you get, unfortunately, a glove stuck to the child as you're gluing a wound, then you can use chloramphenicol for that too. Absolute top tip, then if you've got a child who's got, for example, 2 fingers stuck together, then use some hot chocolate granules. I know this sounds weird. Don't get water on them, so use them dry for their abrasive action, and just rub the granules gradually between the 2 surfaces that you're trying to separate. And the abrasive action of the granules is likely to break down the glue, and then you can gradually work the 2 surfaces apart, and generally speaking, then you haven't caused trauma to either surface. That's my top tip for ungluing things that shouldn't have been glued together in A&E. I'm moving on to any questions now, and I can see that somebody said, is it worth trying Vita while you're waiting for theatres in case of a nearly necrotic toe? I think if you've got a toe that's nearly necrotic, then you've probably got some skin breakdown as well. So we probably wouldn't use the hair removal cream in that instance. But I think I would get orthos to have a look at that urgently. So I think, yeah, I think I would refer that on rather than using hair removal cream. Do you store hot chocolate granules and beet in your department? Yes, we do. And we've got a cupboard with a head torch and all of that jazz in as well, because it makes our lives a lot easier, and that would be my recommendation. Sam, drinking chocolate is better because it's a bit more abrasive than cocoa powder. And if you've got a vending machine with hot chocolate in, you can just use it out of there. Can you demonstrate the use of steri-strips on wounds? We've got some videos about using steri-strips on the Don't Forget the Bubbles website, and I can share the links for that with Harris later, so you can see that. I don't tend to use steri-strips on eyelids. I have very occasionally, in a still child, used glue on an eyelid, and I tend to use it with the sponge adapter on the end of the glue rather than the nozzle, because that usually works. How to examine a through and through wound on a toddler's tongue? Yeah, with difficulty. I usually try and get them to play a game with it, get them to stick their tongue out and make it into a game and go for shameless bribery with that. I have to say, generally, they're not through and through. But yeah, you've just got to do your best with that. Go for stickers as bribery. No, I don't prescribe antibiotic ear drops after removing foreign bodies from ears. Generally, there's no damage either to the ear canal or to the tympanic membrane, so it's not required. Salt and sugar, yeah, I'm sure you could. It just sounds nicer to use hot chocolate powder, and equally probably coffee as well. I'm just a children's nurse, so I like to use the chocolate powder. Okay, are there any more questions for me at this point?
Becky, there was a question earlier on by Noor, I think, about re-implanting teeth. How long does it take for the re-implanted tooth to reattach?
I think that MaxFax generally check them in 24 hours and then a few days later. And I think we normally know within a week or so whether it's going to work. But I always think if you can get them back into the gum within 60 minutes or really as soon as you see them, that's your bit done. And then just make sure that MaxFax are following them up. Okay. Thank you everyone. I'm sorry for the technical issues in the middle, but thank you so much for having me today.
Thank you, Becky. That was nothing compared to yesterday's tech issues. I've just shared above a YouTube link to them. Don't forget the Bubbles pediatric procedures videos. There's more coming soon, but they are really good, so it's worth having a look. Yeah. Please don't forget your feedback forms. And just to remind everyone, we've got 2 sessions tomorrow, one at 1 o'clock on minor incidents, totally different topic, looking at some data from Grenfell. And then in the evening, we're talking DKA. So hope to see some of you there. Have a good rest of your day.
Thanks, Harris.
Thank you.